Hey y'all, we're going to get started with the vascular and interventional radiology core exam review for 2026. This first section is going to be on anatomy. So here's our anatomy review. How this is going to work in general is I'll introduce the case. I recommend that you pause the video, give yourself some time to think of the answer, and then I'll move on to the next slide. All right, so case 1. Name the anatomy. So this is a lower extremity angiogram. And in general, there's a couple things that we should be familiar with. The first branch point from the popliteal artery is going to be your anterior tibial. Anterior tibial comes off here and then goes down the extremity to supply the dorsalis pedis. Next, you have your tibioperineal trunk that courses medially, and from that you have two main branches in typical anatomy. One is the posterior tibial, and the other is the perineal. So you're going to go from medial to lateral, posterior tibial, perineal, and then anterior tibial. We can see that this angiogram here is pretty extensive lower extremity peripheral arterial disease, particularly involving the anterior tibial artery, and the perineal is actually pretty hypertrophied in relation to the posterior tibial. Here's more of a typical 3-vessel runoff on a normal lower extremity angiogram. All right, case 2. Name the structures. All right, so this is an ultrasound image, axial. We're looking at the portomesenteric confluence here. And then the aorta here. Here's your spine. That's giving some shadowing. So we got our aorta, portomesenteric confluence, our splenic vein coming into the portomesenteric confluence. Between the aorta and portomesenteric confluence is going to be your SMA here. And then here's going to be your GDA, and we're partially imaged the IVC here. So GDA, portomesenteric confluence, splenic vein, SMA, and aorta on a axial ultrasound image. All right, name the anatomy. Pretty much name as many of these numbered vessels as you can. All right, so this is a celiac angiogram with pretty conventional anatomy. Main branches are going to be your celiac trunk here. You have your splenic, your left gastric. This is going to be your common hepatic, number 4 here, before it gives off your GDA, and then proper hepatic, which then gives rise to both your left and your right hepatic arteries. Here, forming this pitchfork appearance or trident appearance, is actually your cystic artery. Swinging back down here, 6, we have our GDA, and then we'll move to 12, which is going to be your supraduodenal artery, which typically comes off either the proper hepatic, and kind of can have a variable origin. It's a minor branch. 13 is going to be your anterior superior pancreaticoduodenal artery. 14 is going to be your anterior inferior pancreaticoduodenal artery, and then 15 is going to be your IPDA here, and then 16 is your gastropaploic running along the greater curvature of the stomach here. So these are the exhaustive list of conventional celiac anatomy. Again, you probably are only going to be responsible for the major branches, but here's a celiac angiogram. All right, name the vessels that are labeled here. These are 2 vessels that are involved in forming collaterals, basically, between 2 arterial systems. All right, so this is an SMA angiogram. We're injecting the superior mesenteric artery. We see our typical branches, but we're also opacifying portions of the splenic flexure and descending colon, which is not typical for the SMA territory. That should really just be your small bowel, your jejunal ileal branches, and then your right colon and middle colon. colonic area. So what we see here are two important collaterals between the SMA and the IMA. The more medial is the arc of Rheolin. This comes up here and forms this arcade. And then you've got your marginal artery, which is the most lateral marginal artery of Drummond, that runs along the kind of anti-mesenteric surface of the colon here, and again is anastomosing with the SMA. So this patient probably has an IMA occlusion, so the majority of the blood supply to the colon in its entirety is coming from the SMA. All right, here's case 4B. Name the variants. All right, so what we're seeing here is a replaced, in this case it's actually an accessory right hepatic artery. This is a celiac angiogram, and we see that there's portions of the right hepatic that are opacified here, but we're missing a segment, and it's arising off of the SMA. So this is an accessory right hepatic rather than a completely replaced right hepatic artery. This is just noting the vessel through straight sign, which indicates that there's some sort of variant vasculature. This is when you see a vessel running through the ligamentum arteriosum here. Just indicates on cross-sectional imaging that there's some sort of variant. Typically, when I see this, it usually means that there's a gastrohepatic trunk. All right. Tell me what we're injecting here and what is the critical finding. All right, so circled in red is the critical finding. So this is an intercostal angiogram. So we're injecting an intercostal on the left, and we see proximally there's this structure with the characteristic hairpin torn. This is the artery of Adamkowitz, otherwise known as the anterior spinal artery. This is an important artery to identify because you absolutely should not embolize from here because you would cause paralysis. In this case, the artery of Adamkowitz or anterior spinal artery, it has a variable origin, but typically is on the left, somewhere between around T9 through T12. So again, that characteristic hairpin loop, that's artery of Adamkowitz, anterior spinal artery, do not embolize. All right, this is another variant here that we see. Name the variant and tell me what's being injected. All right, so this is an arc of Buehler. Arc of Buehler is a persistent embryonic connection between the SMA and the celiac. It's not present in all individuals. Again, it's a persistent embryologic structure, so it's not necessarily a normal structure that we see. We're injecting the SMA here, and we see we're opacifying the celiac. A lot of it is coming through the arc of Buehler, but also there's a good amount of retrograde flow, so likely this patient has some sort of celiac stenosis would be my guess. All right, case 7, name the structures. All right, so this is an upper extremity angiogram. We're injecting from basically the level of the subclavian artery on the right. Structure number 1 is going to be your subclavian artery. This is going to be your thyrocervical trunk extending cranially. Once we passed our first rib here, we're going to be at the level of the axillary artery. That's then going to run to the teres major, and after the teres major becomes the brachial artery at number 4. All right, lots of labeled structures here, but just going to ask you to name the 2 labeled structures here, 1 and 2. All right, so this is an upper extremity angiogram. Here's the radial head here. So we're injecting the upper extremity. This structure here is going to be your ulnar running along the ulna, and this is going to be your radial artery running along the radial, the radius. How you can tell the difference, it can be tough. Often the ulnar is going to give off your common interosseous here. So you look for something that has a branch point going towards the wrist, and that's going to likely be your ulnar artery. You can also look for your radial recurrent, or you can use bony landmarks if they're so nice as to give you an unsubtracted image. All right, tell me what is being injected here and what the structures are. Okay, so this is a upper extremity venogram, and going from 1 to 6, we have our SVC, our left brachiocephalic vein here, that then gives rise to our subclavian here. Here's the inflow from our left internal jugular vein that would be coming down and joining in here. Once we pass that first rib, just like on the arterial side, we're going to then become the axillary. And then the axillary vein gives rise to the paired deep brachial veins here, and that's number 6. These are our brachial veins extending down the lower extremity. So this is a normal upper extremity venogram. All right, case 10. Tell me what is being injected and name as many of these structures as you can. Okay, so this is basically a bilateral pelvic angiogram. Looking on the left side here, we have our left common iliac artery. We have our left internal iliac, so we got our internal here, our external here. We then have of the internal, we're going to have a posterior and anterior division of the internal iliac. So 3 is going to be our posterior division going off to give off our superior gluteal. That's the ILS acronym. The superior gluteal, the iliolumbar, and the lateral sacral coming off of that posterior division. Anterior division, internal iliac coming down here, and then we don't get into the weeds on the anterior division branches here. 6 is going to be our common femoral. 7 is going to be our profunda. It gives off this kind of branching pattern as it goes deep, and 8 is going to be our SFA. Okay, tell me what procedure is being done, or what is being injected, and what anatomic variant we see. All right, this is a percutaneous transhepatic cholangiogram, or a PTC. We're injecting some right-sided ducts and opacifying the entire system. So what we're seeing here is we have a right posterior duct that's arising from the left common hepatic duct, which is the most common anatomic biliary variant here. This, you can see that there's this kind of rat tail lesion here indicating some sort of pancreatic head mass or mass here that's obstructing the CVD, likely why this is being done. But the important takeaway here is that we have this right posterior duct that's arising from the left, again, the most common variant in the biliary system. Here's some of the biliary ductal anatomy. We have our normal anatomy here, where you're going to have, up here we can see our right common hepatic, our left common hepatic come into a common hepatic duct, and then our CVD. In a trifurcation, you're basically going to have everything that comes together, the right anterior, right posterior, and the left side to a common orifice, and then this is our right posterior duct arising from the left, which again we just saw in that last case. Okay, tell me what we see here, what variant this is, and what you would do if you were placing an IVC filter. Here's some cross-sectional to help. You can see the filter's already been placed. But what we're seeing here is this is basically a cavogram. This patient has a partially duplicated cava with a dominant left-sided cava here. So we're injecting, and we see here's basically what should be our iliac confluence, and it's just giving rise to this structure that's going up into this left renal vein and then draining into the system, and then we have this very vestigial kind of right-sided IVC, which is where the cava normally should be. So this is kind of like a duplicated IVC. You can think of it that way. So anytime you have duplication of your cava, you've got a couple options. One is you can either put 2 filters in the iliacs, on either side, or you can place one suprarenal filter. In this case, they elected to place a suprarenal filter. This again is just an axial image a little bit lower, and we just see both cavas on either side of the aorta. All right, case 13, we're continuing with kind of our caval variants. Tell me what you see here and what's going on. It can be a little tough. So this is going to be an injection at the level of, here's the diaphragm and here's the heart. So we're injecting a structure up here, and we see that there's this tubular structure going cranially that then drains into the heart superiorly. So remember, in a normal cava, what you would expect is, it comes up into the right atrium and drains here. So we're injecting a structure that's kind of going behind everything and then continuing downwards into the abdomen. So this is a persistent azygous continuation of the IVC. And here's the CT correlate. Again, what you would see is you see this big plump structure next to the aorta. That's not an arterial structure. Again, it's got different contrast in it, but this is that azygous vein that's going to basically, it's acting as the IVC. It goes draining everything back into the heart because there's no IVC to drain into. Okay, here's another cavogram. So this case is a circumaortic left renal vein. We see we're injecting the left renal vein here. There's a structure that goes down and then over and then drains into the cava. So this is a circumaortic renal vein, important for IVC filter placement because you want to place your filter below this lowest moiety. Because again, if you place it here, you think, oh, I'm below the renal vein. Clot can come up, travel through here, go around, and basically bypass your filter and go straight to the lungs. All right, so these are a summary slide, caval variants, implications for filter placement. There's some associated with heterotaxy syndrome, particularly the azygous continuation of the IVC. All right, moving on, case 15, what is the arrow pointing to? Okay, this is a IMA injection, and we're pointing to the superior rectal artery. So rectal vascular supply to the rectum, it involves multiple vascular territories. So the superior rectal, which is going to be the largest typically, there's some variants. This arises from the IMA, but then you've got supply from your middle and inferior rectal arteries that are coming from your iliac system. So your right, in this case, here's the right internal iliac. It's going to give rise to your middle rectal on both sides, and then your internal pudendal artery, which is going to be an anterior branch of your anterior division. Internal iliac artery is giving rise to your inferior rectal artery. So these are all things that can form robust collaterals if there's an occlusion somewhere, and also things to keep in mind if you're ever doing hemorrhoidal artery embolization, so you get complete treatment. All right, tell me what variant we are seeing here. All right, so this is an example of a high origin of the radial artery. So here is the elbow that I've annotated. You wouldn't be able to really tell that otherwise. This is actually during a what looks like an AV graft evaluation. You can see that there's this structure here coming off way above the elbow that continues downwards, and they tied into this for their fistula, but this is a high origin of the radial artery. And again, it's coming off the brachial well above the elbow, so not where you would expect the radial artery to originally take off. All right, on this one, tell me what we're seeing, what variant we have here, and what procedure is being done. All right, so this is an injection of the external iliac on the left. We can see we've come up and over with a catheter. We're injecting, probably going after this bleed from the inferior epigastric here. So going through our structures, we've got one is our external iliac artery. Two is going to be our inferior epigastric. This is our deep circumflex iliac here. And then this structure here, this is actually going to be a corona mortis variant, basically where the pudendal, the obturator is coming off of the inferior epigastric here, and it's crossing over the pelvic brim. So this is an important variant for trauma. This is a CT where somebody's actually bleeding from their corona mortis variant, but you can see it here. It's continuing over the pelvic brim here. Again, it crosses this bony tuberance, and this is important because in trauma, if there's a fracture or some sort of traumatic injury to this area, you have a big honking artery right in the way that can cause serious pelvic exsanguination, or even in the setting of orthopedic surgery, this can become injured. Aberrant origin of the obturator from the inferior epigastric. You can get some sort of variance where it's like not quite the obturator is taking off, but there's just this robust kind of collateralization between a normal obturator coming from the iliac system and then some smaller robust collaterals coming from the external iliac near that inferior epigastric origin. All right, case 18. What anatomic variant do we see here? Okay, this one's a little bit tough because it's kind of like disorienting, I would say. But what we're seeing here is we're doing an injection of the internal iliac system. So we've got our superior gluteal here. We've got some branches down here. This is probably our inferior gluteal. And then we have this big structure that's just continuing downwards past everything, going down the extremity. So this is a persistent sciatic artery. Here's the MRA, and you can see it's this big thing here. So they have actually one on this side too, but it's not quite as robust. It's a persistent sciatic artery, so it's an embryologic persistent structure from development, basically. And it basically goes and supplies the lower extremity. So there's, I hear on vascular surgery boards, they'll say that a patient has a completely occluded, CFA, but they have robust lower extremity pulses. What's the variant? And that is a persistent sciatic artery. This is an anatomic variant, continuation of the internal iliac through the sciatic foramen to support the leg. Complications can be aneurysm formation. So this was a case of a persistent sciatic artery that formed this huge aneurysm that we ended up having to coil off. But they can undergo aneurysmal degeneration. This one's actually really nice because you can see how it's going through the sciatic frame, and the other one was kind of going straight down. This one went at almost a 90-degree angle through the sciatic foramen. Hence why it's called the persistent sciatic artery. It's following that kind of same pathway. All right, case 19. Name the structures. All right, so this is a portal triad ultrasound. We're looking at basically a sagittal view through the body. Here's the gallbladder, the liver. We have our Mickey Mouse here. So the center is the portal vein. Higher up, top screen left is going to be the common bile duct, and then the hepatic artery. So that portal triad is going to be the portal vein, the common bile duct, and the hepatic artery. The hepatic artery is going to be closest to the IVC here. It's going to be the most inferior structure of that portal triad. All right, and then this is also a multiple choice, but still anatomy related. So which axis would have the highest risk of stroke? All right, answer is going to be right radial artery. Again, we typically do left radial for radial procedures, and that's because by going on the left side, we just sneak right down, we avoid crossing the arch, and we go down to do our visceral intervention. If you do right radial, you're going to be coming across, and you're going to cross all of these great vessels coming off of the aorta, increasing the probability of flicking off some plaque going cranially and causing a stroke. So right radial artery has the highest access risk of stroke. All right, and that is anatomy. So we'll go on with part 2 here shortly with hepatobiliary interventions.